Hello dear doctors, nurses, medical students and healthcare team. How are you today? I hope you are well. Here we are going to talk about another question of cardiology. Okay. A 55-year-old man with a history of myocardial infarction 3 years ago presents with progressive dyspnea. It means that he has pulmonary edema after an MRI. He has had 2 previous admissions with heart failure. He has a history of heart failure also in the past year and complains of the inability to lie down flat on his bed. As we said, it's the presentation of pulmonary edema because of heart failure. He has a respiratory rate of 31 breaths per minute and a systolic blood pressure of 90 mm Hg. His oxygen saturation is 90% on room air. On examination, he looks pale and sweaty and has widespread crepitations over both lung folds. It means that he has pleural effusion. Okay, oxygen by face mask was commenced. He has pulmonary effusion. Okay, oxygen by face mask was commenced. What is the single most appropriate investigation? Okay. A. Chest X-ray. B. Computer tomography scan for the chest. C. Electrocardiogram. D. Full blood count. And E. D-dimer test. As we can see, we have 2 important ones here. First, chest X-ray and the second, electrocardiogram. Both are important, but according to the sign and symptom of the patient, the better choice is chest X-ray. Okay, explanation. The patient is suffering from acute pulmonary edema brought upon by heart failure. While it's true that an ECG is important to look for arrhythmia, a chest X-ray would be a better answer given that it would be able to confirm pulmonary edema. This question is very debatable, but the clinical picture here fits a pulmonary edema slightly better than a myocardial infarction. In reality, both will be performed in their clinic. We must do both of them. First ECG, it's so simple, and then chest X-ray. Okay, key finding, as we can see here, the patient's chest X-ray, it has clear pulmonary edema. Okay, key findings on chest X-ray in acute pulmonary edema: bilateral peripheral shadowing, blunting of costophrenic angles, fluid in fissure. Fluid can collect in fissures that separate the lobes of the lungs. Kerley B lines, which are short, thin horizontal lines seen at the lung periphery, particularly in the lower lung zones, indicating thickening of the interlobular septa. And batwing appearance, cardiomegaly, bronchograms, and increased vascular markings. Upper lobe diversion or cephalization of vessels. The upper lobe vessels may appear more prominent than the lower lobe vessels, indicating a redirection of blood flow. As we can see in this chest X-ray, we can see batwing appearance here. We can see accumulation of fluid in costophrenic angle or costophrenic angle blunting. It means the accumulation of fluid, and we can see cardiomegaly here. The cardiothoracic ratio is increased in both of our patients. The cardiothoracic ratio is increased. We can see Kerley B lines here, the horizontal lines, and pleural effusion. We can see cephalization of vessels, as we said. This was a short explanation of the patient coming with acute pulmonary edema, and the treatment of acute pulmonary edema, we explain it on our other YouTube videos. You can watch them for better information. Thank you for your attention.